Good afternoon. We have with us Dr. Sushrita Bandyopadhyay, Director of Critical Care, Amri Hospital, Salt Lake, Kolkata. We welcome you to the Natco Pharma Studio this afternoon, and we look forward to listening to your advice to the young generation doctors. Those are associated with critical care and in bacterial resistance. Doctor, how have you foreseen the changes in critical care management?
As a whole, if you tell how people should approach critical care, I think time has come for the critical care specialists to sort of project themselves as critical care as well as acute care medicine. A part of critical care is associated with the resuscitation of the patient, stabilization of the patient, maybe ventilating the patient, maintaining the blood pressure, etc. That we are expert. But after the initial stabilization and resuscitation, you need a good medical diagnosis. Unless you do that, you might be missing many of your patients who are having maybe something out of the ordinary diseases. Sometimes you not a plain clear-cut pneumonia, a plain clear-cut microbial infarction. All patients are not like that. They may come with mixed diseases, or may come with something novel. Unless you can make a good diagnosis of these things, you won't be succeeding or you won't be making a name for yourself. So please pay attention to the fact a part of your training is, of course, stabilization and resuscitation. But a major part of your training you should be also practicing acute internal medicine so that you can diagnose and treat a patient properly.
Great. You have actually brought in a lot of points for the second question, but I still want to ask you, what is that one advice you like to give the ICU doctors, especially of the current generation, in how they can enhance patient care?
Again, as I've told you, that please see a patient and try to find syndromes. Don't just treat numbers, just low blood pressure, a low oxygen saturation, a metabolic acidosis. Don't treat patients like that. Of course, they're important. They're good parameter, important parameters, and they need to be corrected, fine. But try to come to a syndrome, a diagnosis that this patient has got this. Unless you do that, you only treat the numbers, you'd be after sometimes your sort of graph of patient improvement will become flat. Initial after resuscitation, the patient will not improve unless you've got a syndrome.
Thank you so much for that advice. And what is the prevalence of carbapenems in your line of practice? What are the treatment options?
A large part of our critical care management right now is handling multi-drug resistant organisms, which occur in most of the ICUs across India and right now across the world too. And in India, a major chunk of these multi-drug resistant organisms are gram negatives, and almost, I mean, major chunk means what? Almost 90% of them are some sort of carbapenem resistance, these resistant germs of this resistant germs. And so you need to be up to date about how you treat carbapenem resistant germs. Three major or common carbapenem resistant germs in Indian ICUs right now are carbapenem resistant Enterobacter like Klebsiella pneumoniae, sometimes E. coli, carbapenem resistant Acinetobacter or crab, what we call, and carbapenem resistant Pseudomonas aeruginosa. Right now they are called Pseudomonas aeruginosa, difficult to treat and resistant, DTR. So these are the three things you need to handle, and many of the hospitals will have serious infections with one of these drugs. Right now in my hospital, possibly the major infection with the CRE, that is a carbapenem resistant Enterobacter. So the treatment protocol is right now what we have available in Indian market, and the drugs we have got recommendations like this. Usually these patients who are CRE, that is carbapenem resistant Enterobacter, they are treated with ceftazidime avibactam combination with or without aztreonam. That will depend on, nowadays we have got test, this PCR based test, which will give you what type of resistance the germs have. So they can be producing something called a KPC. They can be producing OXA48 or New Delhi methyl beta-lactamase. These are all names of extended spectrum beta-lactamases which destroy carbapenem. So if it is a KPC, which is low in number in India or very low in number in India, that is ceftazidime avibactam is good enough. If it is OXA48, again, ceftazidime avibactam as a single agent is good enough. If it is an NDM, they are resistant to ceftazidime avibactam, but this can be bypassed by using aztreonam along with that. So this is how you deal with them. Next is your CRAB, that is the carbapenem resistant Acinetobacter. For that, right now the treatment of choice would be any of the polymyxins. If they're lung, blood, abdomen, there will be polymyxin B. If they're urine, then it would be polymyxin E or what we call cholesterol. Along with the second drug is needed. Sometimes we use sulbactam in a very high dose, 3 gram thrice daily. Note that this dose of sulbactam is independent of his spectrum to treat Acinetobacter only. That is only against Acinetobacter sulbactam has got. Sulbactam per se is not an antibiotic. It's a BLI, that is a beta lactamase inhibitor. But here in very high dose, it selectively acts against carbapenem producing Acinetobacter, and it would not be picked up by normal culture sensitivity reports. So you'll have to use it sort of by its pedigree. I mean, not you don't get any culture positivity. And then sometimes these are also sensitive to tigecycline or minocycline. If the infection is in blood, minocycline might be preferred over tigecycline. And for the difficult to treat resistant Klebsiella pseudomonas, that is DTR pseudomonas, again the mainstay of therapy would be your polymyxins, either polymyxin B or polymyxin E, that is colistin. And sometimes they're also sensitive to aminoglycosides, sometimes they're sensitive to fluoroquinolone, so you need to add that. So that is in short how you handle these resistant germs.
Dr. Sushrita, you have actually shared your entire wisdom in the healthcare space, and we value this time that you spent with us in the studio. Thank you so much. We are grateful. All the best to you in your practice.